Hi, I'm Jonathan Kohler.
And I'm Ben Ethan.
We're here to talk to you today about supraglottic airways and just airway management in children. There's nothing really more scary than taking care of a sick child, particularly one who's having an airway emergency. So hopefully knowing a little bit more about how these things work will just help you feel a little bit more comfortable in the moment. Ben, let's talk about how we think about a child who's having an airway emergency or whose airway is compromised.
Absolutely. So first thing you want to remember is that always go back to your basics. So before you start thinking about advanced airways, whether they be supraglottic tubes, whether they be endotracheal tubes, remember that bag mask ventilation and airway manipulation are by far going to be the most likely to succeed in decreasing that child's risk of death. So before you get into the second, third, fourth steps, make sure you know how to do the basics and do them extremely well. The first thing you're going to want to do is make sure that you have the properly sized equipment. And so we have obviously a range of bag mask ventilation devices. So from the very small kind of up into the larger adult size. With pediatrics, a lot of times we have trouble sizing, and so you want to have a variety of all the equipment you have, from small to large. What I say as a good rule of thumb is figure out what size you think you need, and then go one size smaller and one size larger, and have a 3-part plan. The one thing also to remember with peds is because of their size variation, sometimes you need to do adjustments. So most of the bag masks that I use have these ports where you can actually add some more air into the mask so that if you're not getting a great seal, you can make some adjustments. So anytime you do a bag mask ventilation, just make sure you have a syringe so that you can either decrease or increase the amount of air within the bag. Then you want to actually make sure you have a bag that works as well. So again, size range. So this is kind of a standard adult size bag. They do come a little bit larger and they certainly come smaller, but you want to know whatever bags you use, you want to know how they work. So for example, if this one is a self-inflating bag, it doesn't need to be hooked up to oxygen, but it does have the ability to. So if you do want to give supplemental oxygen, you can, but it doesn't require flow, as opposed to more like a Mapleson bag that would. Also, you want to know if your bag has a PEEP valve. If at all possible, make sure you do have one, especially in kids, because as you decrease that reserve that they have, you can get into trouble. This one also has a filter on, and so in the time of infectious disease, you want to make sure that anytime there's a risk of spreading infection, we take steps to mitigate that. And so, for example, if I'm going to bag mask a child, that's going to cause their airway mucosa to spread whatever pathogens they have in there. So anytime you have to bag a child, you want to make sure you have a filter, if at all possible. The other thing to keep in mind is if you have a valve, because sometimes, as you said, Jonathan, it's very concerning when you have a child that's in danger, and the knee-jerk reaction is to bag very hard and very fast, and you don't want to do trauma because kids have very small lungs. So many of the bags come pre-installed with these dials next to the valve, and so it'll tell you kind of how much pressure you're giving. They make these for adults as well, but more often than not, I see them on pediatric-sized bags. So if you have that ability, please use it.
And then one really important thing to remember too is that if you have a bag that's too big, that's much less of a problem, particularly if you're paying attention to those pressures. Whereas a bag that's too small is never going to work to give you adequate ventilation of a larger patient.
Yes, absolutely. This would not do much for me, so please don't use this one.
Let's talk now about the two sort of most common supraglottic airways that we have available.
Absolutely. So supraglottic is just a way of saying we're not going to place anything below the vocal cords or through the glottis. And so kind of the two main ones that we see are going to be the king, and this is more similar to the combi tube that many of you may, if you have the gray hair in the room, you might have remembered the combi tubes that we use to place. This is similar to that, but instead it only has one place to hook up a bag, and there's only one lumen. And so essentially what this does is you're going to place this into the esophagus. This part is going to blow up and kind of obstruct air from coming back out the mouth, and then there's ports that drive the air up towards the trachea. So just to give you an idea what they look like when they're seated, after you place this, you're going to use the syringe that comes with it. There's also some lubrication to help make you successful in placing it. And you're going to want to instill air. The recommendation is going to be on the tube for how much air you want to instill. As you do that, you'll see that sometimes it's a lot more air than people think, especially if you've ever done an endotracheal tube. You're never going to put this much air in an endotracheal tube balloon, but in these tubes, it's a lot different. So after you get it inflated to the correct size, you can kind of notice the shape. And this is where the air is directed up and again towards the trachea because of this little balloon that's divoted.
That's awesome. Something that I learned just recently, actually, is that you can actually put a suction catheter down at least some of these king tubes.
Absolutely. So the king tubes come in different varieties. So you want to make sure you know what you have in your facility. Some of them have this port that says OG and it has a catheter size. that can be helpful for two reasons. One, it's going to be a passive valve, so that once you place it and start bag ventilation, it's going to allow air to escape. But you can also actually send either an OG or a suction catheter down. You want to make sure it comes out the tip and then pulled back so that when you place it, it's in the right spot. You can then, once it's seated, you can drive that down into the esophagus, into the stomach, hook it out to suction, and then you can decompress the stomach after you do insertion.
You ever see passive decompression?
I have. It is definitely one of those things that you'll see once, and then you'll always know where the barrel is. You want to make sure that good rule of thumb is to aim towards the rookie because it is a learning opportunity. So make sure you know where the contents will be making their exit if that is something you'll see.
And that same device or same hole is present on this. This is the eye gel, right?
Absolutely. So the eye gel is going to be more similar to the LMAs that we see in hospital settings, or some pre-hospital used to have more LMAs before the eye gels became popular. And so the traditional LMA will have the part that goes into the larynx, and this is going to be usually either air-filled, or in the case of an eye gel, it's gel-filled. This will sit in the back of the airway. The gel will actually start to mold to the airway to make it a better seal. And then you can attach your bag here and drive air, again, upwards towards the trachea. They also do have that suction port as well. So many of them will have the side port. Not all of them do, so just make sure you understand if your devices have this or not. But you can do the same thing with preloading it. Again, you want to make sure, one, that it's going to pass through, because the size can be a little bit misconceiving. There is a little bit of a turn as well, so just make sure that the catheter goes in easily. Pull it back, seat it, and then again, you can drive this down into through the esophagus into the stomach to decompress as well.
Now, before we go and talk about exactly how we know that these devices are in the right place, let's talk just quickly about sizing.
Yep.
And something that I had actually thought until today is that the colors on these devices would correspond to the Broslow tape size of these patients. But it turns out that's completely wrong.
It's a good idea. Unfortunately, it wasn't one that was had by the people that invented these at that point. So the colors are actually different. So if you notice, there's a lot of colors that are similar, but their sizes are not the same. So for example, the size 5, or the largest size of eye gels that I have here, would correspond to one of the mid-range 2.5s in the King tube. So just make sure that you know whatever you have and how to size them. And as you mentioned, there are different sizing requirements for different devices. So for example, the eye gels are going to be weight-based, and so they'll tell you on the side of the tube, on the package, on the insert, this is the size range in kilos for the patients. Know that you can estimate, but also that if you do have a Broslow, even though the colors don't match, it can give you help in determining what range of size you think. For the King tubes, you gotta be a little bit careful because there is variation within the Kings. So for the smaller sizes, things smaller than a 2, so the 1.5, the 1, etc., those are gonna be weight-based, and the 2 on up, those are gonna be height or length-based. So you just wanna make sure you know, based on your availability of products, how you size what you have.
So really get to know the product that you have at your individual service, but know that there's all these options, which I had no idea.
And one of the things that we also say is, thankfully this is a fairly rare event in EMS that we have to secure a child's airway or ventilate through a bag mask or a supraclavic tube. So it's one of those things that you want muscle memory. So I highly recommend getting out and putting hands on these devices and trying them in a variety of mannequins situations, because they are a little bit cumbersome the first few times you do them. And if you don't have the muscle memory, it's an easy skill to forget.
Why don't you and I go and do that right now, and we'll show you how you can be sure that these things are in the right place. All right, now let's talk about how you put a supraglottic airway into a patient and know that it's in the right place.
All right, well, let's do the King airway first. So why don't we start with the 3 sizes that we think we're gonna need. The one that I believe in, one size smaller, one size larger if we could. All right. So I think we're gonna need a 3. And so if we can, we're gonna see if there's a port. Is there a port for the OG tube on these tubes, Jonathan?
There isn't on this King. This doesn't have an OG port.
Okay. So what we're going to do then is make sure we have all of our equipment. So Jonathan, can we make sure we have a syringe? It's going to be at least 50 to 60 cc's. And if you check the tube, it'll tell me how much air I should be putting in the tube.
All right, this says 45 to 60. I'm going to give you 60.
Okay. And then we're going to look for lubrication if we can, so it makes it easier.
Okay, I think these are all lubed up.
Okay.
Yep.
So then what I'm going to do is I'm going to take the bag mask, set it aside. Dr. Kohler is going to bag for me once I get the tube in.
I'll be ready
I want
here.
to make sure I open the airway, and what I'm going to use is my fingers, so my thumb and my middle finger. are going to extend like that and open the airway. You want to make sure the child is nice and asleep, because if I do this in an awake child, I will be bitten, and you cannot put a king airway, an eye gel, or anything into an oral pharynx of a child who's awake. So I want to make sure the child is good and asleep. I'm going to open the airway wide. I'm going to take my tube. I choke up usually, so I'm holding it just about at the balloon. I'm going to direct it down, feel it make some passing movements. There might be a little bit of resistance. I feel it seat, and then I'm going to push and feel a good seating. It's not too much pressure, but it's not going to move if I wiggle it just a little bit. I'm going to ask Dr. Kohler for the syringe. I'm going to inflate the balloon, and one of the things I do is I keep my middle finger in the back of the oral pharynx, 1 to stabilize the tube, and 2, I can feel when the balloon is inflating. So I will slowly inflate the balloon. I feel it catching. The balloon is in good position, and then I'll hold the tube while Dr. Kohler places the bag to see if we get good chest rise. Okay. So again, we want to make sure that we're not overly ventilating. We want to see chest rise, but we don't want to see huge excursion.
So just enough to see that chest rising, that tells you you've got enough volume.
Absolutely. And then I'll transition. So obviously this is going to be removed once the child is either waking up or you have a definitive airway situation. But we're going to now show you how to do the eye gels. So Dr. Kohler, again, if we can look at the 3 sizes that I think are most likely. So we're going to do a 2.5, a 3, and a 4.
Okay.
I believe 3 is the right size based on the child's estimated weight, and I'm going to do similar technique. Dr. Kohler, does that one have an exhaust port?
This one does have a port, so we can put a suction catheter in here.
Wonderful. So if you could preload that and make sure it's just at the very end.
All right, I'm taking it all the way to the end.
Okay. Might be a little bit stuck with an airway. Okay.
There we go, it's right at the end.
And then what I'm going to do is I'm going to do the same thing. I'm going to use my scissor technique. I'm going to open the airway, and I also try and grab the tongue so that I don't push the tongue back, because that's one of the things that people fail with, is if you drive the tongue in the back of the oral pharynx, it's going to obstruct the view. So what I'm going to do is going to just get past the tongue and push. It feels like a lot more force than maybe you're used to, but you're not going to do damage. The worst thing that's going to happen is it's going to flip up on itself. But I can feel it seating, and then I'm going to hold the tube, ask Dr. Kohler to put the bag on and see if we can inflate. And then pass the tube a little bit further through the OG port, and I conduct a suction. Okay. So again, we just want chest rise. It doesn't have to be huge excursion, just enough to move it. With both of these devices, you want to know what your securement plan is. So there are some commercially available options, essentially rubber bands that kind of go around and secure it, or kind of the old tried and true is just tape. And so a lot of people will tape them. Some people actually will just leave them in place and have one person's job to hold them. Remember that it's not a secured airway as far as a endotracheal tube, but this is considered an advanced airway, and you can ventilate successfully through these devices if you need to place one.
Once you get that tape on there, even then you got to remember that you've got to always keep a hand on the tube anytime that patient moves, anytime you are thinking you're going to do anything that could potentially dislodge the airway. You need a hand right on the tube, even if there's tape or a securement device in place.
Once we place this device, this is my only job. So I will be at the head no matter, I have no other skill set right now except for make sure this patient's airway stays in and the child stays alive.
Now, anytime you're taking care of a kid, particularly if you don't do it a lot, but even for those of us that do it all the time, you will be scared. That's completely normal. You should be scared. But you need to learn how to sort of harness that fear, take a deep breath, take your own pulse first, right? And then just remember, when you're working with kids, there's going to be a temptation with all that adrenaline to just push really hard, to pull really hard. Just remember, kids are gentle, kids are delicate. You're going to just want to be careful with all your motion with children.
Absolutely.
Thanks so much for joining us today. If you enjoyed this video, please check out our other patient transport and safety videos. If you'd like more information or more training, feel free to reach out to us at safekids@uwhealth.org. Finally, Kids Health Vista and the Wisconsin Emergency Medical Services Association have resources available to help rural EMS services get this pediatric equipment. Feel free to reach out to them as well.